Hello, everyone, and welcome to a new episode of Endo webinars conducted by AT Company. Today, our topic will be about magnification in endodontics. Is it accessory or substantial? Before I start, I would like to thank AT for their initiative of these webinars, especially in these hard times of the coronavirus and the lockdown. I just hope that everything will resolve as soon as possible, and please stay home and stay safe. So, about our topic today, for those who don't know me, I'm Ahmed Al. I'm from Najaf, Iraq. I was graduated from University of Baghdad in 2008, and since that time, most of my practice is mainly dedicated to endodontics. I work only in my own private clinic, and also I have a training center. I'm a silver member of Star Italiano Endodontics, and I'm in the third and final year of MSc in Endodontics at King's College London, under the supervision of Dr. Federico Focci and Prof. Francisco Menocci. And as you know, King's College London has ranked number one as a dental institute in the world. So back to our topic. Before I go deep into the explanation, I assume we will have a different level of audience. So not only specialists, we have GPs and newly graduate. So let's go back to the basics of endodontics. Why do we do root canal treatment? So back to 1965 with Dr. Kakayashi, he made a very great research. Myself, and I'm sure that a lot of endodontists consider this paper as the basis of endodontic treatment. Why? Kakayashi brought 36 total Fisher rods, okay? And these are into two groups. The first group was control group, 15 rods. These groups that they have the normal oral flora. They have the normal bacteria in their oral cavity. And the other group was germ-free bacteria. There was no oral flora in their oral cavities. Both groups were giving germ-free food and distilled water. So the methodology of this research was intentional pulp exposure has been made for the first molars, okay, using carbide burr, and these exposures were left without any treatment or without any seal. And these exposures were filled with debris and food accumulations, okay? And after that, these animals were killed at intervals from 1 to 42 days post-operatively, and the teeth and their periapical tissue will be taken for histopathological examination. So the result for the control group, after 8 days, complete pulpal necrosis with the chronic and established inflammation, even in the most deepest apical portions of the root canal system. Also, there was pus in the apical foramen, and there was microorganisms in the periapical area. And there was no evidence, zero evidence of repair. That happened in 8 days. While the germ-free group, they were giving the same food and the same water. Of the 21, 18 has survived the procedure, and these specimens or these teeth, they were no completely devitalized pulp tissue, while there was only minimal local inflammation adjacent to the site of exposure. All of these pulps were vital, and there was evidence of pulp repair, and there were dentinal bridging after 14 days, and the older specimens, there was a complete bridging formation. And For this reason, we conclude that bacteria are the main etiological factor for pulpal and periapical diseases. So for that reason, the European Society of Endodontology has well defined the endodontology in 2006, that is the science that concerned with anything related to the pulp and periapical tissue. The main disease is apical periodontitis caused mainly by infection, as Kakayashi stated. So the aim of endodontic treatment would be to prevent or cure apical periodontitis. And this is done by two steps in general, which is the elimination of bacteria and their toxins and the pulp tissue from the root canal system. And then we seal that system with a good hermetic seal or three-dimensional filling to prevent the reinfection and the leakage of residual bacteria or their products into the periapical tissues. Theoretically, this may be easy, but you must keep in mind that the root canal system, it's not canals. It's a very complex system that consists of main canals and many isthmuses and anastomoses and accessories, lateral canals, and many portal of exits. So all of these spaces should be cleaned, disinfected, and then filled, because this is very important for the outcomes of our treatment. This is very nice paper by Arnaldo Castellucci. He's one of the pioneers and one of the great authors in endodontics. He's also a gold member of Star Italiano Endodontics. So he described that the endodontic therapy before, or traditionally, was performed using tactile sensation of the clinician because, sorry, we are walking in the black hole. And most of the outcomes were achieved by chance. While the challenges that were faced before become much more easier by the use of magnification, sorry, especially the dental microscope. So this is a very good example of lower molar that we can see the mesiobuccal canals, they are merged or joining at the apical portion. Without the microscope or magnification, we don't know that. And also we can see the isthmus here. It's very evident. So basically, magnification consists of two parts. We have, sorry. We have two types of magnification. We can use the dental loops or dental microscope. So what is the difference? Which one we should use? The use of magnification and illumination is very essential in the practice of endodontics. We can use loops, but the microscope provides more magnification and also more comfortable to work because it's more ergonomic and also better illumination. So this is a very nice picture. I found it in Google. You can compare working without any magnification and the use of different loops, and then the microscope. You can see in the microscope that you have that your back and your neck, they are very straight. Okay, so this is the ergonomics of dental microscope and the loops. This is the difference. The most important thing that differs, the microscope differs from the loops. As we all know, vision, we see things because of the reflected lights from objects. In microscope, the direction of the light and the direction of the vision, they are the same. So there are no shadows, unlike the loops. In the loops, we have two different lines of vision and also a different line of light. So we will have more shadows. And this is evident, and this is very important, especially if you are working in more deep apical parts of the root canal system. You can use, let's say you can use the loops for for the pulp chamber and maybe the coronal part, but for the middle part or the apical part, for sure, you need the microscope. So what are the uses of the microscope in endodontics? So I'm going to compare between many literatures and the practice, everyday practice. So in the diagnosis, this very important paper about the microscope, it says that like a persistently painful tooth after endodontic therapy may be due to untreated or missed canal. Re-examination of the pulp chamber under the microscope uh, will easily locate the orifice or the missed canal. So the most important utility in the microscope, because of the magnification and the better illumination, we will easily see the pulp map, which contain all the orifices. It will lead us to the missed canal or orifices, because as we all know, root canal system is a very complex. Okay, so in 1992, in the University of Pennsylvania, they introduced the microscope in the graduate students. They found that more than 50% of all molars have extra fourth canal, and 30% of all premolars have a third canal, while the anterior teeth, more than 25% of the teeth of the anterior teeth have extra second canal. So what was before described as incidence, now it's very common in the under the microscope. And as you know, any miscanal will affect the outcome of treatment. This is another paper talking about the fourth canal or second mesial canal in the upper first molar and second molars. They stated that 78% of the first molars and also 48% of the second upper molars have mesial 2, MB2 canal. And this can be easily found under the microscope. This is also another paper saying that after examining teeth with the naked eye and microscope, they have found that 50 more canals, they were identified under the microscope that they couldn't find with naked eye. So this is a great percentage, which is 7.8%. Also, another paper saying that root canal orifices under microscope are significantly higher, can be diagnosed than the naked eye. So we have many papers indicating that. Okay, this is another paper about the mandibular molars. 14% of first molars and 80% of second lower molars have extra canal. These canals couldn't be identified under naked eye. Let's go to clinical situation. This is upper first molar. As we can see in the radiograph here, it's a normal. Everything is ordinary. Nothing looks weird. But under the microscope, we could find two mesiobuccal canals and an isthmus between them. And also, there was two distobuccal canals, okay, and very large palatal canal. So there were 5 canals in this upper 6. If you look at the radiograph, you see everything is ordinary, nothing strange. And this is after the preparation and obturation of the canals, okay? This is another example of lower 7. Also in the radiograph, everything is ordinary, okay? Nothing unusual. It was hot pulp, but after examining under the microscope, we have found 3 mesiobuccal canals, okay? So these canals were prepared and obturated. Now we can see. So these things, these extra canals, couldn't be identified with the radiograph. This is another scenario, this time for lower molars. This is lower 7, okay? This patient was referred, and also in the mesial root, there was 3 mesial canals and one large distal canal. Okay, the distal was very large, so I did the obturation for the distal with the MTA, and these are the 3 canals obturated, and this is the final situation. This is for lower 7. This is for lower 6. So as I mentioned, as I explained in the previous 2 situation, there were a third canal in the mesial root of lower molars. While in this case, this is lower 6, there were 2 canals in the mesial root, but in the distal, there were 3 canals. Okay, so in endodontics, you have to expect the unexpected. This is the final situation, 2 canals in the mesial root and 3 canals in the distal root. Another example, this is upper 5. So in the previous cases, I showed on the radiograph, everything was usual, nothing unusual. But we have identified the extra canals under the microscope. While for this case, I can see that there is extra canals. Why? Because there is one main canal that suddenly it disappears, and we all know that there is it divided into more than one canal. So under the microscope, I could find 3 canals. Okay, in this upper 5, and this is the final situation. So this is the importance of the microscope in identifying extra canals. Is there any other uses of microscope? For sure, we can use it the benefit in the minimal invasive dentistry because we remove less tissue. For this example, this patient of lower 4, she was diagnosed with the irreversible pulpitis, symptomatic irreversible pulpitis. Although we need to do a root canal treatment, but we have to deal with the main cause. There was no occlusal caries or occlusal decay, while the decay was cervical. So we have to deal with this issue first. So after laser gingivectomy and the cleaning of the cavity, I have to fill that cavity. I have to ensure a proper seal because this is the main cause of the problem. I did pulp extubation through minimal occlusal cavity, and also I put gutta to make sure that the root canal will not be occluded with the restoration. So the restoration of choice for cervical and root caries is resin modified GIC. And after that, I have finished the root canal treatment through the occlusal approach. And as you can see, the cavity was minimal. I'm not a big fan of truss access or ninja access, but this access was more than enough. Okay. Another example for this lower 5, as we can see, there is mesial decay. Okay, thanks to the microscope, the good magnification and illumination, and also for the new instruments in endodontics for the NITI files, their flexibility. So it was very easy to look inside the canal. I had good visibility of the canal. I could do the preparation, do the irrigation, and also use the ultrasonic activation by Ultra X. And this is the filling, root canal filling, and this is the final situation. So with the use of the microscope, there was no need to remove these extra dentine and enamel because I have access. So other uses of the dental microscope in the calcified canals, it's very, very important for the calcified canals because with normal loops or even high magnification loops, it's not easy to to identify calcified canals in the pulp chamber. While in the microscope, because as I mentioned, better magnification and better illumination, we can easily find the calcified canals through the pulp map. This is a very good example. This patient was referred because the dentist couldn't find any canal. So as we can see, the pulp chamber is calcified here. This is the initial situation. After removing the calcification or stones using ultrasonic instrument, this is the pulp. And after removing the pulp, this was the pulpal floor. Even with the high magnification and illumination, it was not easy to find the orifices of the canals because they were very calcified. So look at this is the mesial-buccal. This it's very tiny, the mesial-buccal orifices, and here is the distal-buccal. After dealing with the ultrasonic tips, it was easy to find these orifices and then prepare the canals. And this is you can differentiate between this situation